This is Transparency, a podcast by Gender Dysphoria Alliance, hosted by Aaron Kimberly and Aaron Terrell. Each week, we'll be joined by people who have personal or professional experience with gender dysphoria and physical transition. We'll also discuss how our trans experiences relate to the concept of gender identity. Join us for a compassionate yet heterodox approach to the question of trans.
In this second episode of our special series on the National Trans Health Summit, we bring you into the room for a presentation by Dr. Dan Karasic. Karasic is the lead author of the mental health chapter of WPATH Standards of Care 8, speaking here about working with patients with autism. We're joined by two Bay Area clinicians who attended the conference to provide commentary on the presentation. Please note that the first minute or so of the audio recording is hard to hear, but it does improve, so stay with us. And with that, let's dive in.
So, autism spectrum disorder and neurodivergence. So, autism spectrum disorder is a developmental disorder in childhood that overlaps with gender dysphoria more than expected for reasons we don't know. But anyone who is doing gender work sees a lot of people with autism spectrum disorder. In addition, there's a whole group of folks who function very well, but have read about autism spectrum disorder and seen aspects that resonate with them. And those are folks that we might not say have a disorder because they're functioning so well, but rather try to engage them with non-pathological frameworks about their disorders. But there are some folks who are, quite impaired. Just a first principle of working with folks with autism spectrum disorder is recognizing that it's not just one thing, and that there are people for whom autism disorder could really impede their transition, and there are other people for whom it really doesn't at all. So it's really a individual assessment of the degree in which they're impacted and how that the ways that they're impacted might affect transition. So this is the DSM-5 autism spectrum disorder. You can see there's two groups of symptoms: persistent deficits in social communication and social interaction, and then restricted repetitive patterns of behavior, interests, or activities. And then they give examples of each of them, and then there's a severity rating. So let's talk about some of the ways that ASD can interact with transition. So first of all, there can be issues with communication with care providers. If you have taken care of some youth with really significant autism spectrum disorder, there are some for whom just engaging and getting them to be able to verbalize their feelings related to gender identity, gender dysphoria, and transition sometimes can be challenging. Although even some youth who are really quite impaired verbally will make their feelings known in other ways. And so it's not really a block so much as sometimes creating a little bit more of a challenge in terms of exploring what you want to explore with a young person.
But it's really important there, right at the beginning of this session, he's saying, even with some patients who are very impaired verbally, that's not necessarily a block. And there are basically not necessarily a block to transition. And there are other ways to explore with them. He doesn't say, yeah. We'll get to some suggestions later on how to get around that.
And he started off saying that there's a huge overlap between gender dysphoria and autism for reasons that are not well understood. So he doesn't sound like he's attempting to explain that correlation. He just states there is that correlation, and therefore, how do we assess those that have autism and make sure that autism isn't a barrier to receiving gender affirming care? Just in case anyone sort of missed that initial bit of the talk.
Yes.
And, some or many mental health clinicians hypothesize that correlation may be due to concrete thinking that can happen with autism, right? And black and white, rigid thinking, and also sensory sensitivities. So all of those things have been thrown out there as ideas about that might explain the correlation.
There's also a theory that there's a connection between autism and high testosterone in both males and females. And that I think Jordan Peterson mentioned this in one of his talks, that because like if a female is in utero exposed to high testosterone, if that is the cause of the autism, that it might also create some masculinization. And there have been studies on facial masculinization in females with autism. So I think it's a contested theory, but it is one of the existing theories of what the correlation is related to.
Those of us in the kind of say gender critical camp of all this, there's a lot of theories as to why those things correlate, and I think there's a lot of truth to all of them. But in the context of Dan Karasic, lead author of the mental health chapter of SOC 8, he has no curiosity about what that overlap is, like where those. It's just like, we don't know. Okay, moving on. How do we like zero curiosity?
Yeah.
You move on. Yeah.
Sorry.
Whether that's in school, with peers, with family, and that, of course, with autism spectrum disorder can be an issue in other realms other than gender, but sometimes impacts, for example, getting family on board with transitioning. The impairment in social communication interaction can make it more difficult to find social support, although I certainly have folks with ASD who actually have pretty robust support networks. Very often, things like within gaming communities or other online communities, and so one shouldn't assume that the people don't find other ways to get social support, but it's certainly something to explore. More challenging, actually, are.
I just want to make sure that people understand that he just said that you might think that they don't have a robust social support network, which is necessary for a successful transition, but not to fear. Most of these people have very online lives, that they have robust social networks in their online gaming community, for example. Just making sure everybody got that's what he said.
Yet that would be a red flag in any other area of mental health. If a youth that their only social interaction is online, I would consider that an impairment of some kind.
Well, in fact, the U.S. Surgeon General just released a statement, calling attention to the problem of social media in youth and how it affects their mental health. And And to compare that to the support of, families that you live with that have known you your whole life, to say that you might get a sufficient support from people on the other end of a computer does seem ridiculous.
And insufficient support from family. I mean, he said it can be hard to get parents on board, parents of autistic kids, because they might think that, the autism may complicate the situation, to say the least. So again, I mean, I think we hear this over and over again. There's this very strong idea about how to get parents on board, right? How to convince them.
That leads me to a really important piece I recently learned about how this happens. Is I was recently on Benjamin Boyce's podcast with Eliza Mondegreen, and we were talking about our various experiences at this conference. She was at WPATH in Ireland around the same time, and when I was talking about this, about the Dan Karasic, and Benjamin Boyce asked me basically, how are parents, why are these kids, if the parent isn't on board with the transition, how are these affirmative mental health providers getting their hands on these nonverbal autistic kids? And I actually heard from Jamie Reed. She answered that question, which was that parents were bringing their children, they would see their kids online, like their internet history, and realize that they're in this gender issue thing going on. They find out about it online, and they bring them to the gender specialist, thinking that that's where they're going to get answers and that's where the kid's going to get help. But really, all they get is medicalization, and the parent gets coerced into medicalization. So that was an incredibly, that I had no idea that's. I was like, that's a great question. How is this situation even arising? It's because the parents clue in on some level that something gender is going on based on the internet history of their child, take them to the clinic thinking that's the actual expert, an actually informed person, and is going to assess the situation, help the kid figure out what's going on. But no, it's just boom, puberty blockers or cross-sex hormones.
Mm-hmm.
I think that same phenomenon happens for a lot of non-autistic kids also. Parents just assume that the gender specialists are going to be the ones who will help them sort out what's happening, not having any idea that, they already have a very specific perspective, which will drive what happens from there.
Yep.
Parents who attribute gender diversity or dysphoria to the intense focus on circumscribed interests of ASD, where, for example, like a parent saying, well, when my child was 9, they were obsessed with vacuum cleaners, and then when they were 12, they only wanted to dress like Justin Bieber. And so I have to explain to them those are two actually very different things. So that they only wanted to dress like Justin Bieber because that's an androgynous way to dress. That wasn't necessarily an obsession of autism spectrum disorder. And I think actually when you or I.
Sorry, the Justin Bieber comment made me laugh, but I just wanted to add to that. Do you know how many lesbians look like Justin Bieber? It could just be that the kid's gay.
Good point.
It was a meme. It was like lesbian or Justin Bieber. Oh man. Okay.
Anyway, I just had to throw that in.
When Sean or I were talking about folks, often we're talking about some of the same patients who share with you. But that's actually something that has been very common. Some of the youth with autism spectrum, their parents, or with actually any like co-occurring mental health condition or even physical disability, sometimes the child is even more dependent on parents than an adolescent would be, whether because they have a smaller social network or because they really, for whatever the condition is, they're really relying on the parent for interaction with the outside world sometimes. But it's really kind of astonishing how many times over the years parents have attributed to their trans kid where it's very clear the kid is trans. They just also happen to have autism spectrum disorder, even like in a minor way, where the parents have kind of convinced themselves that the issues around gender dysphoria and gender expression are just like obsessive, repetitive, interest related to ASD. So, and then in another way, some folks with ASD sometimes have environmental or sensory sensitivity, and that can make, with transition, people have to see doctors and be in sometimes uncomfortable circumstances, whether it's bright lights or just unfamiliar surroundings, or noisy places that for having ASD can sometimes impact that. And I had recently an adult with ASD who had chest surgery, who really was inordinately affected by just the sensation of healing. They had great relief from gender dysphoria having chest surgery, but just all of the different sensory changes in their chest became very, very distracting for them and really disabling, where they couldn't work for a while because they were just so focused on chest sensation. So sometimes people can react differently in ways that could impact transition. That being said, my patients with autism spectrum disorder who need gender affirming medical and surgical care benefit from it just as much as folks who don't have ASD. So it's really more a matter of helping them through the process, as opposed to, if we get back to some of those state laws where they say you have to have, cured the patient's ASD and ADHD before they get into something.
Yeah, I have a question. So when you're working with an individual that is on the spectrum with little to almost none communicative abilities, which does happen. I mean, even if it's autism or high anxiety, connected to.
Yeah.
What would be your suggestion on the assessments that we have to complete, and when you receive pushback, from individuals maybe higher than you, when they're looking at the assessments and saying, oh, there's not enough information here, or wait a minute, parent answered, a majority of those questions, because I have experienced that and I go to bat and then I, accidentally get on my high horse a lot of times. But what would be, what's your suggestion?
Yeah, I think that could be challenging. I have a patient right now that an adolescent with quite severe autism, who I always see with her mother, even though she's 17 now, trans girl. I didn't do the initial evaluation for this person to start hormones, but I would have imagined it would have been difficult. And I've done some evaluation of this person where and given them some advice to take back to their the team, that the child gender team at another nearby university that that's working with that particular patient. Because I do think that's it's challenging and it's building rapport and learning how the person communicates. Sometimes it's accepting some degree of communication with the parent because the parent, recognizing the limitations of that, but sometimes, it's necessary because the parent, is with the youth all the time and can have a better sense of how they're doing it. The particular patient I'm thinking of, um, despite their quite severe autism, is very clearly trans and clearly, benefiting from being on estradiol and if anything is, just impatient for more feminization and wishes they had gotten treated earlier for that reason. Yes.
So, there's this, he's talking about how you sometimes very reluctantly have to deal with the parents of, severely autistic kids because of the limitations of their communication abilities. But it's this, you unfortunately, we sometimes have to include the parents, is the attitude.
He says it very much like, it's very inconvenient that we often have to deal with parents, when treating, these adolescent or minor patients. But it's even more so the case with these autistic kids, unfortunately, is like how he was saying that. But I can't get beyond that thing where he does this multiple times, but where he's basically like, if anything, she wishes, she got more feminization sooner or faster. It's like, did she tell you that? He just like says what he wants to believe. I don't know. It's just
Well, and I mean, there's this, he says she was clearly trans. Again, I mean, this goes back to the fundamental question of what does that mean for a child and adolescent for anyone to be trans, right? As opposed to having gender dysphoria and identifying as trans, right?
Yeah.
We'll have to have an autism specialist on at some point because I have so many questions, that have just accumulated in my head as we've been doing this podcast for a while. But one of the questions I have is, I know with autistic girls do tend to be more gender nonconforming. I mean, Temple Grandin being a classic example. Do any of you happen to know if gender nonconformity is more common in autism in boys as well?
Well, it's not that gender nonconformity is more common in boys. It certainly is with girls. Well, it's there's a facet of autism where just learning social behavior is difficult. So even well before the whole trans explosion, it's well noted that autistic patients or autistic people have trouble with gender, with like performing their sex essentially, which is like something that kind of comes naturally to most people, but with like getting the concepts of kind of like, so I guess the answer is yes, that the males are gender non-conforming as well, but it's not that. I think autistic girls often come off as just naturally like tomboys, essentially, like very kind of masculine, more than other girls. But I think the boys, it's not so much that they're like they're certainly not feminine in their behavior. It's not like going in the female direction. It's just, I think it's just awkwardness that I think some people can choose to interpret as trans. I don't know if you two probably could answer that better than I can, or I could be well off the mark here.
Well, I have many autistic patients as a pediatrician, and I would say I don't know, what makes sense to me is that it's not so much that they're gender non-conforming per se, is that, the whole thing about autism is this difficulty with social communication. And so it seems to me like this gives you a recipe, right, for how to behave. Like, oh, let me tell you exactly how to do it. And if you're not comfortable with the way of behaving that maybe is traditionally associated with your sex, then here's an alternative for you. And it's very clear cut. And if you follow this, then this is a way toward acceptance. So I don't know that it has to do with gender per se, so much as trying to figure out how to be at home in the world when when that doesn't come naturally to you. I don't know.
There's also aspects of autism that this is another thing Jordan Peterson mentioned in one of his videos, that there are aspects of autism that do tend to be more male typical, like, for example, being more preoccupied with objects and things rather than people. So I think that might be more, even though that would be true for both males and females, it probably wouldn't be as noticeable in males if we expect them to be more object oriented and working with their hands and less social.
Mm-hmm.
Yes, that's very true.
Socialization of females to kind of take care of others, right? Be kind, think about the other person's feelings. Those are all things that require capacities that are limited in people with autism.
Even with the classic childhood onset gender dysphoria, so not speaking at all about the ROGD phenomenon, but the classic type of gender dysphoria where it starts at age 3 onward. There is, I can't remember off the top of my head which studies this came out of, but in one of I can't remember if it was Zucker or one of Blanchard's, but it was a persistent study looking at who is more likely to persist or desist from the childhood gender dysphoria, and autism and low socioeconomic status were two of the, of course, there's no solid predictor of persistence, but it said those with autism were more likely to persist, probably because of that very rigid, concrete thinking that once they kind of settled on this, that because of the lack of psychological flexibility, they were probably less likely to work their way out of the gender dysphoria.
That makes sense.
Should we carry on?
I was just thinking to add to that, I think it's really important when we submit an assessment to basically say the problem is with the assessment requirements, and that they're very neurotypically designed.
That is correct.
And that just preface it by, due to that, I used other measures and information to find out about this particular person and essentially educate people around there's different ways of knowing. And if we use the standard template, we're not going to find out. We may have to depend on parents, we may have to depend on drawings, but we can't just say, well, until you can be verbal and answer the questions as we have in this assessment packet, we can't clear you. That's really discriminatory.
Hear that information, consider it an education opportunity, maybe for those above us that don't understand ASD as well as, some clinicians do. Because even though there was obvious communication in some of the assessments that I did, I still got pushback because there was not enough coming from the person themselves and instead from the parent. So it's very, very frustrating because you're correct. It's very, very neurotypical and it drives me crazy. And I'm hoping that in the future we can change that.
Well, it's interesting you mentioned drawing, because this particular patient is able to draw her feelings better than to speak them. And so sometimes that can be, and enjoys drawing much more than enjoys speaking typically.
Yeah.
And so I think that's a good point to bring up that they're.
Can I tell a really sad story? This is a really sad story. This was a child.
But you have to leave it with like a little.
You help me out on this one. So this was a child who came to our clinic at UCSF at age 8, had no language, had been diagnosed as very autistic at age 2. And the only time this child spoke in the initial session was when the parents and the grandmother who came together would say, and when she was little, and this not she, he, that was the only sentence. And basically, this child was in precocious puberty. So we did puberty blockers, the child did a social transition. And the next time they came to our clinic, well, not the next time, for one of the subsequent visits, walked in, shook my hand, actually touched me, and said, "Hello, Dr. Aronstadt." So this was after a social transition. That's the good part. How's that bad? Are you ready? So then this child is approaching puberty now. It has been on blockers for precocious puberty, but the family decides they want to get an independent evaluation. They live in Central California. They found a psychologist who basically said this child cannot be, it's impossible that this child is transgender because on the anatomically correct dolls, they could not distinguish that there was a boy doll and a girl doll based on genitalia. So how could they know their gender? And they detransitioned this child.
Thanks for that, Saz.
So these are the things why we have to keep doing this work and educate as many people. And we kept calling the family and saying they didn't respond.
Let's call that psychology.
Oh yeah. Noted and done.
So moving.
Yeah, I was just saying, I'm kind of speechless. So basically what she's saying is that a child that doesn't understand the difference between males and females would know which they were. Is that kind of the gist of what she's saying?
Yes, that's, it's just preposterous to think that a child who doesn't know, can't discern anatomical differences between males and females wouldn't be trans and wouldn't need to be medicalized. Like, she just finds that absurd.
For me, it seems more like a consent issue, that what is their capacity to consent to these treatments if they don't understand the difference between males or females?
That's right. And also, I mean, maybe it's not that clear in this moment, but it's something that was conveyed repeatedly, is like this psychologist is who the independent psychologist that they received the assessment from is from the Central Valley. And there's just this understanding that those people are conservative, right? And that's why they get in the way of what these trans kids need.
Yeah, as a foreigner, so to speak, the contempt for everybody outside of San Francisco and LA seems pretty palpable. There was the general theme.
And for anything conservative. I mean, I can't think of other areas of medical or psychological practice where there's two completely different streams of practice based on whether you're liberal or conservative. Like, how is it relevant? I mean, if this is solid clinical practice and evidence-based, a person's political affiliation shouldn't matter. But it's something I've seen over and over and over again with, these queer-based trans circles, because the queer ideology is so liberal that they don't make room for anyone that isn't far left.
Mm-hmm.
I also found it curious that when they tried to follow up with this family, they didn't hear back. And it seems like Dr. Aronsoft was making certain assumptions about what that meant, but I don't know why you would make that assumption. I mean, maybe that worked out well for the kid to keep their original sex, and they didn't feel the need to talk anymore with the UCSF gender clinic. So it would actually be quite interesting to know what happened to that. Yeah.
All right. I mean, she prefaced it by saying it's a sad story.
Right, right.
The one that got away.
Yeah.
Yeah, I mean, if had she followed up with, they detransition the child and then the child's mental health decompensated, I mean, that might have completed that loop to why it was a sad story. But yeah, right, like without knowing what is the outcome of that child, maybe they're perfectly happy.
Right.
It's not a sad story unless they were suffering as a result of that decision.
Right.
And I think detransitioned is too strong of a word there. I mean, she was on puberty blockers because of precocious puberty. And then, the social transition, we don't know what that included, but I mean, there's different ways people mean different things by desisting, detransitioning.
Mm-hmm.
But I think she puts it in terms that are too strong, right? That they detransitioned the kid.
Yeah, whereas really they just chose not to proceed with more medical interventions.
Right.
Yeah. Yeah, that's a
Or
good point.
medical interventions specifically, that are related to gender identity.
Mm-hmm.
Right? She was only on puberty blockers for precocious puberty, which is an entirely different thing.
Yeah.
All right.
Gone. Because there was no side to that story.
Don't do that.
Except for maybe that Sean and I have had a mutual client patient who years later was able to transition on her own. But yours, we don't know. Maybe it was happy. I just don't know it. Okay, so let's talk about depression, anxiety, and anxiety with transition. So these are very common things, depression, anxiety among cisgender as well as trans people, among adolescents. But trans people have this additional life challenge related to transition, and depression and anxiety often can get in the way. Depression impairs not only energy and motivation, but also optimism, the idea that things can change for the better. And anxiety can really be obstructing in all kinds of ways for people seeking help or seeking care.
So just to add quickly, so depression and anxiety can get in the way. And obviously he means of medical intervention. He doesn't mean get in the way of working through what the underlying causes are of identifying as trans or of gender dysphoria. Right. It's only, again, the model is that transitioning is the way to go. Medical intervention is what you're supposed to do, or what they need. And these other things, depression, anxiety, can get in the way of that.
It's a very good point that the whole construct seems to, that it's not about resolving the patient's mental turmoil or anything about resolving something internally for the patient. It's just everything. The solution is always pharmaceuticals and surgery.
And in addition, people are anxious and depressed. There's often a social anxiety component. There are greater barriers for obtaining the necessary social support that youth need in particular, but that older folks as well who are anxious and depressed need the support of a large community that can be hard to put together when you're feeling anxious or depressed. However, there are many studies that show benefit from transition, less depression, less anxiety, less suicidality and self-harm. And so it's important, for us to help support people, whether with psychotherapy or medications, to be able to get to that point if they are if they need to transition, if they need medical intervention to be able to get to that point and do that, if they need to socially transition, if they're able. This is just one of many papers. This was from looking at hundreds of patients from Pfizer, both in Northern and Southern California and Georgia. And their clinical takeaway from their data was that withholding or delaying gender confirming treatment until depression or anxiety have been treated may not be the optimal course, given that the benefits of reduced distress after undergoing these interventions. So just supporting the idea that even though it can be more challenging for people who are depressed and anxious to transition, if they need to transition, it's ultimately beneficial for them. And they can use the kind of support to get there. So suicidality and self-harm, these are common things in, as has been talked about earlier, in trans youth and trans adults. But transition has been shown to lessen suicidality and self-harm in large surveys and in clinical observational studies. And so it can be a good thing that lessens suicidality and self-harm in a lot of people. One little caveat, or it can be a big caveat for some people, is that parts of transition can be stressful. So even if they are feeling better at the end, there are things like relationship conflict and loss that can trigger suicidality during transition. There's also can be an increase in minority stress when people during transition might maybe appear more obviously trans in a sense than they did before, and thus be subject to more discrimination or nasty comments that other kinds of stressors. So someone who does have suicidality and self-harm history, certainly, transition can be a good thing for them, but it's important to, kind of monitor how they're doing with suicidality and self-harm. DBT and other psychotherapies in particular can be helpful. Of course, depression and anxiety medications can be helpful.
So he's constantly separating any sort of psychic complexity or suffering, anxiety, depression, from gender dysphoria and from trans identity, as if they're, discrete entities or something. There's no sense of trying to understand how all of these things might be connected. So it's always, basically, how do we get the parents out of the way? How do we get the depression out of the way? How do we get the anxiety out of the way? How do we get the autism out of the way in order to provide these life-saving measures? And I don't know what specific studies he's referring to here, but we do know from the systematic evidence reviews that these studies are of low and very low quality. So we can't rely on these studies that he's citing to basically advance his agenda.
And he also, there's never anything going on in the individual's life that could contribute to the trans identity or the request for transition or anything like that. There's nothing it's never about anything, about the intricacies of this person's life. But then if they transition and the self-harm, suicidality behaviors come back, it's because of something about in their life that's gone wrong, right? A relationship breakdown, or now they're undergoing minority stress due to their transness, right? It's never about being trans, like you're saying. So like it's a discrete, these discrete entities. But yeah, how he frames that is basically there's this loophole, right? That where if the mental health goes downhill after transition, it's because of the intricacies of this person's life completely removed from transition.
It seems related to what I've heard from a lot of detransitioners, that the pathway to the original transition was minimal assessment, but the moment they want to reverse their transition because they feel they've made a mistake, now suddenly they have to go through a whole bunch of assessments and jump through a bunch of hoops. It's sort of an assumption that, well, no, you are trans, so if you regret it, there must be something else going on, that you didn't actually make a mistake, that it must be minority stress, or right. So it's just that contradiction.
One of the reasons why I'm so opposed to the T being in the LGB, because how this is all facilitated is because trans is just like being gay. So you can be gay and, like that doesn't change, if you're, how depressed you are, or how anxious you are, or how, autistic you are, it's like that's your sexual orientation is going to be static through all the roller coasters of life, right? And so that's how they manage to tack on to pretend that trans is also discrete from all of these from all the ups and downs of life, is because of just that gay association that's completely false.
Well, it's the ROGD that complicates that. I mean, I think it made more sense for the T to be part of LGBT when it was a bunch of lesbians and gay men that were transitioning. And then with autogynephilia, I mean, you could argue that is a sexuality, but it's because they've completely divorced gender dysphoria. I mean, talking about the two classic types, divorcing gender dysphoria from sexual orientation, but then still force teaming it with LGBT, or LGB, which is a sexual orientation. But ROGD, I don't think has anything to do with sexuality. So
no, it doesn't. It doesn't. And they would never acknowledge. They would never acknowledge why the T was included in the first place, though. That's the kicker, right? So you and I firmly believe that there is definitely a sexuality component to gender dysphoria of all original types, in my estimation. But the actual people who are advocating this transition for all would, and the T inclusion still would absolutely never, accept that. That's where it's so ridiculous that they continue to or why it's all completely, helpful propaganda, essentially, helpful and inconvenient. They dodge it all very well.
You said that ROGD has nothing to do with sexuality.
Most of the time, I don't think it does. Not in the same way. I mean, I think there are probably some cases of just straight up internalized homophobia that happens, but I think ROGD has become so much more of a social phenomenon than rooted in sexuality.
If anything, I think a lot of the ROGD girls are actually fleeing sexuality. It's like stunting development, essentially. It's avoiding the sexualization of females in a lot of ways, I think.
And the drive to fit into a social group, and I think there's a lot of different motivations behind ROGD, but I don't think it's an organically occurring phenomenon out of sexual orientation in the same way that both autogynephilia and some homosexual transsexuals is.
I see. Yeah, I think, we don't have hard data on this, but I do think, at least for for some ROGD kids, there is, that sexuality is a component. But I think you're making a distinction between, you said something more organic and something social. So it can be internalized homophobia, or again, this equating of gender nonconformance with trans, right? So we don't have data, but my sense from my work and from what I've heard and read is that there are quite a number of, especially girls, females, who are lesbians, and gender nonconforming, who are identifying as trans.
When you when you say that there is a sexuality component to ROGD, I think that's the first I've. But what is that? What you mean? Just by the lesbians who are swept up in it?
Yeah, I mean,
Okay.
I think gay boys too, but I think that might be more the case with lesbians. It's one stream. There are a number of streams, and I think the larger one is, kids who are, lost and find themselves on the fringes and don't know where they belong, and they want a group, or they're just gender nonconforming, or they want to opt out of female sexuality. But I do think that at least some of them, I mean, again, I don't want to say most or anything, we don't know. But I would say that that's definitely a component.
One thing that I found out when I've been like so deep dived into this is so I don't know what the situation is like in the in the therapy room, but online it's very clear that you tell the practitioner you're seeing, that the girls, you tell them that you're a lesbian. That's one of the coaching that's explained online, is because then you're more likely to be believed to be truly trans. But in the actual like in the forums and whatnot, and I spend a lot of time like just kind of learning the culture and whatnot, and the on a granular level, it seems far and away that they're like trying to be queer in some way, and it validity that like I don't know, it's so much about the philosophy and the culture and being part of some sort of movement and whatnot. It seems like actual bodies and actual sexual orientation are just so completely divorced from what the younger people getting into this are the females. Definitely, when I'm talking about ROGD, I'm going to be always talking about females. I'm not sure if it's really a component for the boys, but it's so much about it's the culture and the queer rainbow movement. It's like it seems like the sexuality is just is a card you play in order to pass cis normative tests. Is like how it's understood inside the community.
Mm-hmm.
That's why I mean, yeah, sure. I think certainly, all the whole disappearing butch thing is absolutely a real phenomenon. But I think when we're talking about the teenagers, I don't even, I'm curious how many of them actually know what their actual sexual orientation is. It's so completely divorced from what I.
Yeah.
Well, what I've seen with some ROGD girls is that they identify as gay men, right? Gay boys. So, which I find completely perplexing. And I'd love to hear what you guys think about that.
Well, because
I mean,
there's more social currency to being gay than there is to being like a straight girl.
Right. That's because if you're a straight girl, and that's a lot of people will think that these girls are like fetishizing gay men, and that's what they're. And again, I don't think it has. I think people are trying to make this way more about sexuality than it actually is for these kids. I think it's mostly a case of, well, they're just normal straight girls, but they need to be trans and they need to be queer, and therefore, since they like boys and they're trans, so then they're a gay boy. Like it just doesn't. It's just normal normal, yeah, I think they're far and away just regular, straight girls who have to be queer in some sense. And it's so much more about the the cultural designation and the just we say it too much, but the cult, it's like they have to be queer in some way, and a lot of them claim to be lesbian because that's how they get in, or that's how how they pass the cis normative test as they understand it, the gatekeepers, and then they can be, their true gay self, their true gay boy self after. Like, it's it's so I don't, the Rajdi and sexuality thing is, I just don't think the component is there as much as people think it is. It's my assessment from being in the
Yeah, and the number of gay and lesbians that are getting, swept up into on the trans train, I think that's largely a misinformation campaign. I mean, it used to be kind of well understood that gay and lesbians were more gender nonconforming, and especially as children. I mean, the number of gay boys that are very highly effeminate as boys, and they end up becoming more masculine as once they kind of realize their sexuality and become gay men. But if the messaging was that gender nonconformity exists on a spectrum, with the far end being what we might call gender dysphoria, historically, it was only those adults that gender dysphoria persisted and was very severe that were transitioning. But if you're telling people that gender nonconformity or any degree of gender dysphoria automatically means you're trans, that they're now sort of slapping these kids with a trans label without giving them an opportunity to resolve that and become happy, healthy gay and lesbians, because that's not the message families and the kids are receiving. So I think there's a lot of sort of sub-threshold, if you can kind of call gender dysphoria, a clinical threshold. I think there's a lot of sub-threshold kids being swept up on the trans train who probably would have just desisted and become gay or lesbian. But so I think it's largely misinformation that's driving that they get slapped with a trans label prematurely.
Mm-hmm. But I will say, I mean, I maybe it's not as big of a factor. Maybe there aren't as many, gay and lesbian, let's say adolescents who are identifying as trans, but I don't want to sweep it out under the rug entirely, because it's definitely something I see in my work. And again, mostly with females, although I happen to, more of my practice involves females, but and that's not to say they even have any sort of real connection to their sexuality, to their sexuality. They're not kind of, my sense is that they're dissociated or split off from their sexual desire, right? I don't know if these girls kind of experiment with their bodies in any way, or even if we're talking about masturbation or something, but they do talk about having crushes on girls, and so I think, I mean, oftentimes when I'm thinking, well, she's a lesbian, even if we don't know that, like, she hasn't had any sexual encounters yet, but she's talking about being attracted to girls or having crushes on them. So to my mind, that kind of suggests a more, that they might be bisexual or lesbian. So I think it's there. I don't know. I think it's much more complicated than that. And again, like what you're saying, that there's this, being cis and straight is the worst thing in the world these days. So there's a lot of trying to move away from that and be something different.
Yeah, there's a lot of cases, and I think I get in trouble for this, but I do think female sexuality is a lot more fluid and socially malleable than male sexuality. So I think too, a lot of these girls can get themselves so entrenched in the ideology and so entrenched, or not. It's just it's the water that they swim in. Is that they to be just a normal straight girl is just they just cannot do that. They just cannot be that. And so they won't let themselves dwell on the boys that they're kind of more naturally developing crushes on. I mean, I know obviously they're absolutely 100% genuinely lesbian teenagers, but I mean, like, it's rare. Actual female homosexuality is very rare, but Rajdi is incredibly common, and I think because it's a culture that's completely devoid of or completely unrelated. I'm repeating myself, but like, I just it's like they'll only focus on the girls that they think are probably cool or they admire or they are, and then it's funneled into a crush when, and again, it could genuinely be a crush, but it could also just be like who they need to be focusing their budding attentions on. I don't know. It's all so, it's just so constructed and so forced and so about, yeah.
Well, and crushes are sometimes more about we want to be like that person rather than we want that person.
Yeah.
Right.
Yeah.
And next, I wanted to talk about the mental health chapter in SOC 8. So that chapter is specifically related to people with significant mental illness or substance use who are also transitioning. So it has some broader implications than that. But in that regard, we had already decided, I think probably many of us kind of felt shortly after Transgender 7 came out that the relatively well-controlled and well-controlled descriptors were not really the best ones. This came up in Transgender 7, but the European gender clinics use this idea of well-controlled and relatively well-controlled just get a referral to the clinic from kind of general care, and we really couldn't get consensus with SOC7 to change with that, but we were able to do that for SOC 8, including some of the same leaders of European gender centers. And in that interim between 2011 and 2022, we had the considerable experience in American healthcare of providing transition care to people with often severe mental illness who needed transition care as Medicaid opened up population of folks who were disabled by mental illness to be able to get transition care. And so we were coming from a stronger voice, I think, in the US at that point. So there have been many discussions about things that both the well-controlled criteria and other issues related to transgender care for people with mental illness and substance use, including their care in inpatient and residential facilities, and these were discussed at various WPATH and USPATH conferences. And I just briefly wanted to just go through a set of examples in my experience showing the need for better guidelines than what we had in Transgender 7. So the first one was a state correctional agency that was that their expert was denying surgery to incarcerated people because we pretty much thought that all incarcerated people had personality disorders that weren't well controlled, so that they were in jail. And so they were just wholesale, even though the health system, the state had agreed, in court to provide this care. And in fact, they were denying it for this reason. Another example was a case where a young trans man, psychiatrist and therapist were reluctant to provide a letter for chest surgery due to this history of suicidal thoughts and depression. And this was in a 18-year-old, where it was very clear that the chest dysphoria was a strong contributor to their suicidal thoughts and depression. And the surgeon actually reached out to me, and the patient came to see me for an assessment. Person did have chest surgery and did very well, had a substantial relief of depression and suicidality. Another one is insurance and healthcare systems denying coverage for surgery because of psychiatric hospitalization within the last however many months. That would be their policy without really any data to support that, except for saying, well, that shows that their minimums not well controlled. An extreme form of denial of care was state psychiatric hospital from another state other than this one, where every trans person who was admitted to this state hospital would get cut off from their hormones and not get them until they were released. And the reason that was given by the doctor there was that since they're in this psychiatric hospital that they can't consent for hormones, they don't have capacity for consent, and that their mental illness was not well controlled. Also, well, obviously they're in a psychiatric hospital, their mental illness is not well controlled. So, when in fact, it was probably reflecting bias at that hospital about treating trans people with hormones. So just a few more. Well, this was one I saw in a state forensic hospital where they allowed a patient with associative identity disorder to transition after they made a lot of progress with that and identified as a trans man. They were on testosterone for an extended period of time until a new psychiatrist took over the ward and forcibly detransitioned the patient after getting a consult from a forensic department at another medical university, say in the Central Valley. And other than that. So I kind of thought about it when you mentioned it, maybe avoid the Central Valley for those kinds of consultations. And this is someone who eventually, thanks to legal advocacy and work that I did over a decade, was eventually allowed to, they were allowed to transition in terms of hormones and social transition back just after I saw them in the 2000s, but then it was another decade before they were doing surgery at state forensic facilities in the state of California. So sadly, this person waited a decade with terrible dysphoria around his chest. Eventually, after I saw said that not only did he need chest surgery, but hysterectomy and cardioplasty, and the state actually ended up providing all those things and also finally discharged him, and he's doing extraordinarily well. Another one was an adolescent trans girl that I saw within early transition, had lived, as a girl for, most of her life in terms of social transition and then puberty blockers and hormones. And but I saw this call for depression and prescribed an SSRI, which causes suicidal ideation. And it can happen in, this black box warning in adolescents. The parents took their daughter to an emergency room. All of the Bay Area hospitals were full. They eventually admitted her to the hospitals further out, where she was treated very well by the day staff, but the weekend staff misgendered her, kind of thus outing her to the other youth on the ward, and the child called her parents, who took her out against medical advice. And so just, the treatment, even in the greater Bay Area, it's maybe by the mile as you get out of San Francisco and Berkeley. But it still leaves a lot to be desired. And then just patient surgery has been postponed because they had preoperative urine test positive for a nicotine metabolite. And then experts on anti-trans care proposing that youth should accept their bodies as an alternative to transition, even when saying, oh no, that's not conversion care. So just have a few minutes, but so we had this is our mental health chapter. We had folks from Turkey, Belgium, and Sweden, as well as a number of folks from the U.S. We had 3 of the 7 folks on the committee were trans identified. They're all mental health providers. And through phone, Zoom, email, we came to consensus on 20 statements for our chapter. The editors of SSC provided feedback. They cut our number of statements in half because some of them, they said, were just basically good practice. And I think they were just basically trying to keep SOC8 from being War and Peace. But saying that statements had to be kind of recommendations, really action statements, recommendations that providers can make that were beyond just being a good provider. Our 10 statements went to this Delphi process where you had to get 75% approval. If you didn't, it would write in feedback, and if you didn't get 75%, it could be the statement could be revised and submitted for another round of Delphi. This is that kind of large consensus building process. All of our 10 statements were approved on the first pass. So there was a release of the SSC8 draft, and there was an opportunity for people in each chapter to communicate with other chapters about discrepancies and trying to make all of the chapters consistent through response to public comments, final editing, and final results. So just briefly, and you can read these, but the first one was that that conditions that interfere with capacity consent have to be addressed. Of course, people have to be able to consent to care. Importantly, rather than conditions being having to be well controlled, that there's simply an assessment of mental health symptoms that can interfere with the capacity to participate in perioperative care, and making a care plan essentially to be able to assist the patient with mental illness to be able to get through care. So as long as they have capacity to consent, it's more of a process of working with a mentally ill patient towards best outcome, as opposed to mental illness being blocked. And then that mental health symptoms or
he's I'm not sure if he's basically just he's going through what it currently says in the mental health chapter of SOC 8, like what they ultimately decided on, right? Which was like just to evaluate for the capacity to consent. And Aaron, I know when you were doing the assessments back before you left that clinic, all you were allowed to do was to assess for the capacity to consent. There's nothing else to be assessed there. But even since SOC 8 was written at this conference, we saw a shift. Diane Arensaf just said it earlier in the session that, basically ability to consent, to verbally consent it's just, to assess for that is discriminatory. So they've already moved beyond what they published, 6 months ago?
I don't know what they consider criteria for, the capacity to consent. They're saying, people with intellectual disabilities have the capacity to consent, right? People, severely autistic, nonverbal people have the capacity to consent. Children have the capacity to consent. Aaron Saff said, never say a schizophrenic person can't also be trans. Like, on what basis does someone not have the capacity to consent?
Yeah. I didn't read the mental health chapter of SOC 8 very thoroughly. I kind of want to now because I wonder if it may have been a bit more liberal, let's say, than I had initially suspected.
I think it's based on the principle of like comparing it to being gay, that
right.
that if you're gay, then why can't you be gay and have schizophrenia, or gay and have cognitive disabilities? And so because that's how they're thinking about it and framing it, they're looking for any excuse possible. Why can't you be trans and have schizophrenia? So so in their mind, they don't want to see any of those things as a barrier. But you're right. I mean, it really calls into question, what is the capacity to consent then?
And, if capacity to consent implies that we know what we're consenting to, and given the lack of evidence, there's no informed consent. You have to be informed. We don't have that data, right, to be able to make an informed decision.
Yeah, it calls into question both the both two sentences in that, or both two words in that phrase.
Yeah,
informed and consent. Neither of those two are existing here.
And especially since what we're arguing isn't, the capacity to consent assessment isn't about their identity. I mean, people don't need my permission to identify with whatever they want, but the capacity to consent is about these irreversible medical interventions.
But they're just pretending otherwise. They're pretending it's about the identity. Yeah.
As if you can't be trans-identified unless you have these medical interventions.
Mm-hmm. Well, I don't think they see it as an identity. Like you're saying, I mean, they see it like sexual orientation, right? Something you're born with, or just some sort of inherent, innate thing.
They how they see it changes depending on the context, right? So it's like it's an identity sometimes, or it's an inherent unchangeable thing, or it's expansive and varying throughout the course of your life. But
the identity can be separate, right? Like, remember Sean Giametti, who is a trans man, right? Who said that he identifies as a gay man and is married to a woman who identifies as a lesbian.
And you pointed out your confusion at that. I mentioned how heteronormative it is to think that words have meaning.
It stuck in my mind the next day. I texted you, like, I'm still thinking about this. How are you
Yeah.
a gay man married to a lesbian?
Yeah. Yeah. Because literally those words don't mean what you think they mean. Yeah.
Well, but I brought that up because it's there's identity. So he identifies as a gay man, but is also a trans man who's right. There's a separation. They do what they do in order to serve what they're saying. You're right. So sometimes it's an identity, sometimes it's innate, sometimes it's both, sometimes it's who knows what. Right.
It's whatever it has to be.
Or a web that keeps getting woven until you're, for the rest of your life.
That's right.
We've got 15 minutes left. Should we power through?
Let's go.
The type of surgery that somebody's having should be weighed in terms of the impact that mental health symptoms can have on the person, and balloplasty being, an example of the most involved surgery that people might need more mental resources to get through. Psychosocial support for surgery should be built. That was something that came through between cancer care 7 and 8. Mental health providers should address tobacco and nicotine use. And the reason we put this in there is that is, can block the patient from being able to access surgery, because people have worse healing for oxygenation of tissues. And so surgeons often will test for nicotine metabolites. And there was a big study where in cisgender people getting plastic surgery, that where 10% of people who had said they were ex-smokers actually had nicotine metabolites in their system the night before surgery. So it's a quite addictive thing, and just the idea of addressing this early on if you're working with clients, so they have some get there. So then, very importantly, maintaining hormones for inpatients. So this idea that that the baseline is people off hormones, but that's not true. If somebody is entering a inpatient setting, whether medical or psychiatric, and are on hormones, the default should be to continue them on hormones unless there's a very specific contraindication, like somebody's being admitted for DBT, for example. Respecting gender in inpatient and residential settings, and maybe that we, and at this point we shouldn't need to say this, but even in fairly progressive places, people get misgendered and allowed to access, whether it's sleeping situations or restrooms, or when they're trying to heal from whether it's mental illness or medical illness, you don't need that extra stress, as well as potential rupture with rapport with the caregivers. And we know that there are dangers for not recognizing patients. Social support is, the mental health professionals should, part of therapy, be working with patients on building a support network. People, though, should not be required to have psychotherapy before accessing psychotherapy care. There's only a requirement for an assessment, and that can be done by a care provider or mental health professional. There's no psychotherapy requirement to access care, and there are people who don't like psychotherapy but benefit from it. And then we repeated our statement from Transgender 7 in opposition to conversion there. So I think those are just the cases again. We are just about out of time, but we maybe could take a question or two. Yes.
So I work at a tribal hospital, and this is making me think, when I'm on call, if I have a patient who is taking clinical therapy, that should be part of the criteria I use when I'm calling hospitals for beds. That I should be asking if they, because most of the hospitals I refer to are in Arizona for psychiatric hospitalization. So should that be one of the questions I'm asking?
So are you on the phone and communicating with that person? So I think I would say, you know, when you're talking about medications they're on, you know, that they're on, you know, listing the hormones or other medicines that they're on and saying that that is, you know, part of their treatment plan and just trying to make sure that that's not going to be disrupted.
Yeah, and then if they won't take my word for it, I'll get the ER doc to also do that. Yeah. And then maybe do I send over the guidelines too and say, FYI?
Because you need that, them to take that bed, and they're saying they're going to stop the person's hormones and you can't find another place for them, then I certainly would send a copy of the guidelines to reinforce your position. Because unfortunately the people who most need to have, you know, read the standards of care are the people who never read the standards of care. Okay, I think we'll finish, and the last session I think is back in the big room.
The people who most need to read the standards of care are the people who are least likely to read it. I grew up hearing the exact same thing about the Bible. Would you believe it?
So he forgot to include the part about, you know, the new part about the eunuch identity. Wonder why.
Well, he was only covering the mental health chapter, right?
Okay. Giving a bit of a doubt. All right.
But I do wonder, what if, you know, because no psychosocial, he's saying no psychological assessment is needed for, you know, to transition. And now eunuch identity is something that you can just transition into. So no psychological assessment needed for elective orchiectomy.
Yeah, come on, Aaron. Yeah, no discrimination. I mean, people with severe autism can still have castration fetishes. I mean, don't be a bigot. But you notice the wording that he used. He said, so you paraphrase saying you don't need psychotherapy prior to medical transition, but the word he actually used was you don't need psychotherapy prior to receiving care. Right. Which makes it sound so much worse, right? As if psychotherapy isn't care.
Yep.
Right.
I think what's worse is that care is euphemism for transition in this context, right? Care means medical transition. Yeah.
I was also wondering this when he says you don't need psychotherapy. It does seem that even if you're truly trans, whatever that means, and you go through this, it just seems like psychosocial support from a therapist would be so essential to figure out who you are going to be in this world. And I was, you know, they completely dismissed that. Like, no, all we have to do is change your body and you're good to go.
Mm-hmm.
And next week we're going to do the APA's guidelines, and they basically are very clear about that. It's like that a psychologist's job is not basically your trans identity has nothing to do with why you would see a psychologist, is kind of how they're framing it. So that seems to be the position, is that, you know, you're trans just like you're gay, and like you don't need psychotherapy about that. You know, you'll need it for something else, and the psychologists just need to be equipped to work with a patient of this demographic, is essentially how it's now conceived of.
So if it's not about identity, is it about gender dysphoria? And if it's about gender dysphoria, then why is no assessment needed? Like, is gender
Yeah.
dysphoria not a
Well,
physical?
gender dysphoria is something that happens to people who have minority stresses due to their trans identity in a cisnormative world. So gender dysphoria is just it's a basically how they understand it or how they frame it is gender dysphoria is something that develops due to minority stress of being a trans person. The transness precedes the gender dysphoria, which is created due to cisnormative discrimination.
But what about the desire to, get rid of one's breasts, right? Or like there is some, even in their framework, there's some recognition of distress in the body.
They kind of, that's what I kind of, again, like we're kind of jumping into the APA, what they covered there, but it's almost like they seem to just stop their brain from going there, from thinking about that, and they just call it embodiment goals. And it's just like, they don't think about, what, they don't allow themselves to actually think about the distress that would lead somebody to want to alter their body that drastically. It's just about, it's an embodiment goal, like getting a piercing. It's very, they have to minimize it. Is how it works. Yeah. Well, thanks again for being here with us.
Yeah, thank you.
Until next time.
Thanks for joining us for this episode of the Transparency Podcast. If you enjoy our content, please help out our algorithm by hitting like or subscribe. If you'd like to make a donation, follow the link to our PayPal account. On behalf of the Gender Dysphoria Alliance, thanks for your support.